suggested metastatic disease, so we do a PET scan. When you do an FDG PET scan, the brain will light up. Sometimes you'll see left ventricular shadow. You'll see the left kidney, right kidney, urinary bladder. Every other white spot you are looking at here, though, are metastatic sites. So she has diffuse metastatic paraganglioma. We use FDG PET to determine the extent of disease. Here's a patient with a 50-year-old woman with SDHB mutation, a 24-year course, and you see she has multiple metastatic sites. Here's a 54-year-old woman, mutation negative, 37-year course, multiple metastatic sites. Here's a patient with SDHD deletion, 17-year course, several metastatic sites, chest, left pelvis. We can use FDG PET to monitor tumor progression to decide when to intervene with chemotherapy. We have no cure for metastatic pheochromocytoma and paraganglioma, so many times we observe these patients and intervene with chemotherapy when tumor bulk is becoming significant. So we can just watch maybe a couple of these sites over time. How about this spot here in the right femur and this spot here in a left rib? If you follow those in serial PET scans, you can see she is developing progressive disease. And it was at this time in May of 2006 that we initiated chemotherapy. You can also use it to monitor the efficacy of your therapy. Here's a different patient with fairly widely spread metastatic disease. This is a PET scan in March of 2006. She went on CVD chemotherapy for 8 months, and she had a fairly dramatic response. CVD, cyclophosphamide, vincristine, dacarbazine, does not cure malignant pheo, but it does cause some tumor regression, as shown here. Selective venous sampling for catecholamines is usually misleading and should be avoided. This is a study we published in March, adrenal venous sampling for catecholamines, a normal value study. What do I mean by that? Well, about twice a year, we'll see a patient at Mayo Clinic that has spells, impressive spells, but normal biochemistry. But the clinician's so impressed with the spells, they do a CAT scan. CAT scan's normal, but they're so impressed with the spells, they'll do adrenal vein sampling. And almost always, it's the right adrenal gland that's much higher than the left adrenal gland. Because of that, they recommend right adrenalectomy. The patient has their right adrenal removed. After surgery, the patient still has spells. And then they refer them to Mayo Clinic. And I'm the one that has to tell them they don't have a pheochromocytoma. So we decided to use the data that we've been collecting for other reasons just to show this fact. So these were 18 patients that had bilateral adrenal nodules, but they either had ACTH-independent Cushing syndrome or subclinical Cushing syndrome. We did adrenal vein sampling to see where's the cortisol coming from, the right or left. We measured catecholamines to document that our radiologist successfully catheterized both adrenal veins. So here is epinephrine data. This is a log scale, right adrenal vein, left adrenal vein. You can see in all but about 3 patients, the right adrenal vein epinephrine is much higher than the left. The median was 2-fold higher, but there was one patient as much as 83-fold higher on the right compared to the left. Here we're just dividing the right adrenal vein catechol by the left adrenal vein catechol. This is epinephrine, norepinephrine, dopamine. So it's mostly for epinephrine where we see the dramatic step up on the right, less so for norepinephrine and not as much for dopamine. So why is this? It's just a simple anatomic issue. When you put a catheter in the right adrenal vein, that's a short adrenal vein just coming off the IVC. When the catheter's in the adrenal vein, it's in the adrenal medulla. It is stimulating that right adrenal gland. On the left, it's actually distant from where the adrenal medulla is. It's where the adrenal vein and the inferior phrenic vein come together. So it's actually not in the adrenal gland on the left. So it's an anatomic issue. It's a local stimulus issue. The tumor can always be found in a symptomatic patient with a pheo. The average diameter, these aren't small. These aren't like aldosterone-producing adenomas. The average diameter is 4.5 centimeters. So if you're having trouble localizing a pheo, it's usually because your patient does not have a pheo and you've ignored some of the biochemical diagnostic tips that I've suggested today. MRI is overrated. Somehow it's crept into the endocrine literature that MRI is a superior test to a CT scan. It's not. It doesn't give you as good a spatial resolution. I'd take a CT scan any day. Now, an MRI doesn't have radiation associated with it, and that's its major advantage. Epinephrine, metanephrine predominant tumors will always be localized to the adrenal medulla or organ of Zuckerkandl. To go from norepinephrine to metanephrine, to go from norepinephrine to epinephrine, you need high levels of cortisol. So it's only going to happen in the adrenal medulla. We don't know why it happens. Organ of Zuckerkandl, which is at the bifurcation of the aorta. Norepinephrine, normetanephrine predominant tumors may arise from the adrenal medulla or from sympathetic paraganglia in the abdomen, pelvis, chest, or neck. So you can't reverse that. In other words, I see clinicians say, oh, it's a norepinephrine tumor, therefore it's a paraganglioma. No. Remember, 85% of catecholamine-screened tumors are in the adrenal gland. So most norepinephrine tumors are in the adrenal gland. The only time you can use the catechol profile to localize a pheo is if it's an epinephrine-metanephrine tumor. MIBG is taken up by normal adrenal glands, and it's usually asymmetric. Inexperienced radiologists will typically call the left adrenal suspicious on MIBG scintigraphy because it's much more easily seen. So you should never remove an adrenal gland based on MIBG alone. You need to show there's an adrenal mass there. And again, a symptomatic pheo is going to be 4.5 centimeters or larger in diameter. So we see this type of patient I'm about to show you about twice a year, where they have the left adrenal resected. So adrenal venous sampling, they take out the right adrenal gland inappropriately. With MIBG, they take out the left adrenal gland inappropriately. Here's a 44-year-old man, new onset hypertension and spells, 24-hour urine. In the Mayo lab, this would have been normal, but in the reference lab they were using, they had operable normal of 500 micrograms instead of 900. So the clinician said, aha, my patient has a pheo, ignoring the fact that if you have a spell patient, the lab value should be markedly elevated, not mildly elevated. Here's the MIBG scan. It was I1, I think it was I-123. Here's the left adrenal gland that the radiologist read as left adrenal pheo, because you can see it. They did a CT scan. The radiologist read it showing left adrenal mass, which is that tiny, 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 tiny thing right there. Barely can see it. So the patient had laparoscopic left adrenal alectomy and had a normal adrenal gland. This should be no surprise. But now the patient's in my office. He wants to know, why did they take out my left adrenal gland? So I had to explain to him some MIBG pearls. There's a normal asymmetry between the right and left adrenal gland on MIBG scintigraphy. It's easier to see the left. It's not hidden in the liver shadow. And a symptomatic pheo needs a sizable factory. This isn't like primary aldo. Average size, 4.5 centimeters. So this patient is doing okay, but he has one adrenal gland. He actually had panic disorder. All of his spells were nocturnal. We treated him appropriately for panic disorder, and he's a happy guy now. Genetic testing. 15 to 20% of patients with pheochromocytoma have disease-causing germline mutations. Hereditary pheochromocytoma tumors typically present at a younger age than sporadic tumors. So genetic testing should be considered in a patient with one of these following 5 circumstances. Paragangliomas. 33 to 50% of all patients with paragangliomas have a germline mutation, typically in succinate dehydrogenase. Bilateral adrenal pheo, always genetic. Unilateral adrenal pheo and a family history of pheo, genetic. Unilateral adrenal pheo at a young age, at least think about it could be a germline mutation. Or if you have unilateral adrenal pheo and there's something on the patient's phenotype, whether it's multiple cafe OA spots for NF1 or bumpy lips for MEN2B, you should think genetic. Always involve a genetic counselor. Most endocrinologists just don't know enough about germline mutation testing and the implications for the patient, implications for the family. So it's good to involve a genetic counselor. Again, bilateral pheo always has a genetic cause. It's going to be MEN2, von Hippel-Lindau, neurofibromatosis type 1, or succinate dehydrogenase mutations. Unilateral pheo, only do genetic testing if you have a good reason. A good reason would be, for example, less than age 30 or a positive family history. Paraganglioma, as I mentioned, we offer genetic testing to all patients with paragangliomas. We typically do site-directed succinate dehydrogenase mutation testing, SDHB mutations, if the patient has abdominal, pelvic, or chest disease, so SDHB for belly. If SDHB is negative, we do SDHD. If it's head and neck, then we typically do SDHD first, followed by SDHC, followed by SDHB mutation testing. It's important to recognize there are genetic forms of pheo and paraganglioma that have yet to be discovered. We have families that are mutation negative for all the known mutations. So whether you do mutation testing or not, I always recommend all first-degree relatives, parents, siblings, children, have biochemical testing for pheo. Let me conclude with some comments on treatment. Combined alpha and beta blockade is one approach to control blood pressure and prevent intraoperative hypertensive crises. We typically start with alpha blockade, phenoxybenzamine 7 to 10 days pre-op to normalize blood pressure and expand the contracted blood volume. Blood pressure should be monitored twice a day. We do this in the outpatient setting. Target blood pressure typically less than 120/80, but that's age adjusted. If I have a 23-year-old, my target systolic is going to be about 100 millimeters of mercury. Heart rate target typically around 80 beats per minute. You modify the targets based on patient age and comorbid disease. On the second or third day of alpha blockade, we start the patient on a high sodium diet, pickles, potato chips, pizza, popcorn, fast food. So it's easy to do in the United States. I like to get their intake to over 5,000 milligrams per day. We need to volume expand these people. When you hear about centers where they say, well, blood pressure, when we treat our patients with phenoxybenzamine, post-op, the blood pressure drops incredibly low. That's because the patient was not volume expanded. Now, clearly you need to be cautious. If your patient has renal failure or congestive heart failure, you have to be very cautious when you do the volume expansion step. After adequate alpha blockade has been achieved, then we add a beta blocker. Typically, we do this cautiously. Usually, we'd use propranolol, 10 milligram tablets, 10 milligrams Q6 hours on day 1. If they do well with that, we switch them to a cardioselective beta blocker and long-acting on day 2. There's a small fraction of these patients have a catechol cardiomyopathy. When you give them a beta blocker, they go into pulmonary edema. So this needs to be done under observation and cautiously. The last oral doses of alpha and beta blockers are given early in the morning on the day of surgery. Long-term follow-up, 1 to 2 weeks post-op, we measure fractionated METs in cats, 24-hour urine or plasma. If these levels are normal, the resection of the pheo should be considered complete. Increased levels of CATs and METs detected post-op are consistent with residual tumor, either a second primary lesion or occult metastases. 24-hour urine fractionated METs in cats or plasma METs should be checked annually for life. These patients are at increased risk for recurrent disease. Annual biochemical testing assesses for metastatic disease, tumor recurrence in the adrenal bed, or delayed appearance of multiple primary tumors. Follow-up imaging usually is not needed unless the original tumor was poorly functional. In that case, we periodically would do imaging. So to summarize this presentation, when should we suspect our patient has a pheochromocytoma? Hyperadrenergic spells, episodes of palpitations, diaphoresis, headache, tremor, pallor, resistant hypertension, so 3 drugs, poor control, a familial syndrome that predisposes to pheo or paraganglioma, like MEN2, von Hippel-Lindau, family history of pheo, incidentally discovered adrenal mass, hypertension, and something unique with diabetes. Good glycemic control all of a sudden becomes more difficult for no apparent reason, plus they develop new onset hypertension. Pressor response to anesthesia or surgery, onset of hypertension at a young age, idiopathic dilated cardiomyopathy. The approach, at least at our center, is pretty straightforward. It's a 24-hour urine for fractionated metanephrin and catecholamines. If your patient has spells, you can do a collection on the day they have the spell. Having said that, all pheo patients are leaking out METs and CATs every day, whether they have a spell that day or not. All biochemical tests may be normal in that asymptomatic adrenal incidentalloma patient, and this is where imaging phenotype is critical. I gave you some examples of how pheochromocytomas have to be small sometime, and that's why you can discover these before they have symptoms, before biochemical testing is abnormal. Localization with MIBG scintigraphy is helpful if your abdominal CT is negative or if your patient has a paraganglioma. I showed you an example of how that worked for this young woman that had proved to have metastatic paraganglioma. We don't do FDG PET scans too often, despite the number of images I showed you today. We restrict it mostly to our patients with malignant and metastatic disease to first document that they have malignant disease and then to monitor over time. We discussed the important MIBG trap, where radiologists that are not familiar with reading MIBG scans many times will call the left adrenal suspicious for pheochromocytoma. You have to be very careful with this, and you always have to correlate it with a mass seen on CT or MRI. And I conclude with some comments on treatment. We're still using non-selective alpha blockade followed by beta blockade. We start our alpha blockade typically 7 to 10 days pre-op. We volume expand all these patients, and our target is low normal blood pressure for age. I thank you very much for your attention.
Thank you very much for your very nice speech. We have 5 minutes time. Any question, please?
Hi, good morning, Prof. My name is Fu from KL, Malaysia. You recommend the routinely performing MIBG scan when you suspect a malignant adrenal pheo, large or paraganglioma. So if we do a CT and apart from the primary tumor, we did not see any obvious other metastatic deposits. And if we do the MIBG before the surgery, would let's case if there's a presence of micro metastatics, would the uptake be masked by the presence of the large primary tumor?
So it's a good question. The question is, in a patient with a pheo or a paraganglioma that you've documented on CT, you do a pre-op MIBG scan for the reasons I suggested. Would the uptake at metastatic sites maybe not be detected because so much MIBG is taken up by the primary tumor? The answer is no. Now, having said that, if you truly have micrometastases, you're not going to see that with MIBG scintigraphy. For MIBG to be positive, it needs to be at least 5 millimeters in diameter to be picked up with that imaging modality. So a negative MIBG scan, although reassuring, does not exclude malignant metastatic disease. That's why all these patients need lifelong follow-up, regardless of what the pathologist says. As you may have heard from Dr. Sassano yesterday, it's difficult for the pathologist to distinguish between benign and malignant pheochromocytoma. So if the pathologist says benign pheo, I never believe it. I follow all these patients for life.
Thank you.
Yes, please.
Hi, Dr. Yang. The asymmetry you saw with the adrenomedullary hormones in your study, did you see that with the adrenocortical hormones as well, and to what extent?
Can you just repeat that?
In the adrenal venous sampling,
Adrenal venous sampling.
you reported an asymmetry.
Yeah.
How about adrenocortical hormones, and to what extent?
No. So this asymmetry that we found in catecholamines, where the right adrenal gland catechols are so much higher than the left in normal individuals or in patients with Cushing's, subclinical Cushing's, we do not see this with cortical hormones. What we see with cortical hormones is because on the left, we're sampling just where the inferior phrenic vein comes into the adrenal vein. There's a mild dilution, maybe 20% dilution on the left. So that's why when we're doing adrenal venous sampling for aldosterone, for primary aldo, we'll divide the aldosterone by the cortisol to correct for that very mild dilution. But what we saw with catecholamines, this isn't mild. These are huge differences.
Prof, thank you for that excellent talk, Suyin from Singapore. May I just ask 2 quick questions? In centers where we don't have the 123 MIBG, what's the sensitivity of a 131 MIBG?
Right. So even with I-123 MIBG, there's going to be a 15 to 20% false negative rate. You'll see a similar false negative rate with I-131, and you won't see as many, let's say if the patient has metastatic disease with I-131, you're not going to see as many of the metastatic sites because all you have are those planar images. You don't get that 3D type of look I shared with you. So, yeah, there are some centers in some countries that don't have access to I-123 yet, MIBG, and if that's the case, I-131 is the next best But when you can graduate to I-123, it's definitely a better image.
The second question is for Pheos that you said look clearly like a Pheo on the CT, but are in the pre-biochemical phase. Assuming your surgeon wants to go in and remove it, do these patients have to be blocked as well?
Right. So your patient where you're convinced you have stumbled over a pre-biochemical pheochromocytoma, then they're normotensive and asymptomatic, how should they be prepped for surgery? I prep them exactly the same way I do a symptomatic pheo patient. We start phenoxybenzamine 7 to 10 days pre-op. Our target is low normal systolic for age. These people really need to be volume expanded because you don't want to make them hypotensive. And we add our beta blocker 2-3 days pre-op.
Thank you very much.
Last question, please.
Thank you. Juliana Chen from Hong Kong. Thank you for the lovely lecture. A very pragmatic question. If cost is not an issue, how does a PET scan come in? If the patient doesn't mind paying for it, and given some of the uncertainty regarding all the sort of different imaging, would you go for PET scan?
So if cost is not an issue, PET scan is a spectacular imaging test. The TCA cycle is broken in most patients with pheochromocytoma and paraganglioma. They thrive. If you could somehow block glucose uptake, these tumors would die. So they all take up glucose. So FDG, not DOPA PET and all these other fancier imaging carriers, but just fluorodeoxyglucose is spectacular for pheochromocytoma and paraganglioma. So if cost wasn't an issue, yes, I'd be doing FDG PETs every day.
Okay, thank you.
Thank you.
Thank you very much.
Very good morning to all of you. On behalf of the organizing committee and the AOC 2010, I have the pleasure of introducing Dr. Lober Lustig from the US. And he'll be talking on the role of dietary factors in non-alcoholic fatty liver disease and metabolic syndrome in children. Dr. Lustig is professor of pediatrics in the Division of Endocrinology and head of the weight assessment for teen and child health program at UCSF. He is an internationally recognized authority in the field of neuroendocrinology, with a specific emphasis on the regulation of energy balance by the central nervous system. Dr. Lustig graduated from MIT and received his MD from Cornell University Medical College. He performed his pediatric residency at St. Louis Children's Hospital and his clinical fellowship in UCSF. From there, he spent 6 years as a postdoctoral fellow in neuroendocrinology at the Rockefeller University in New York. Dr. Lustig is currently investigating the contribution of biochemical, neural, hormonal, and genetic influences